I am pleased to welcome you all in today's webinar. Before we start, I would like to give some introduction about NICE, as this webinar is under the umbrella of NICE. Nurses Initiative for Community Empowerment (NICE) is a program initiated by the Indian Society of Emergency and Cardiac Nurses (ISECN), with the aim of empowering nurses to make a positive impact on the community. NICE recognizes the unique position of nurses as frontline healthcare providers and believes that they can play a vital role in promoting health and well-being beyond the clinical settings, with its key features and its objectives. One of the objectives of NICE is empowerment of vulnerable population. So for today's evening, the webinar topic is Introduction of Palliative Care Among Community Healthcare Workers. Patients in need of palliative care are considered to be vulnerable. Palliative care is crucial for improving the quality of life for individuals with serious illness and life-limiting disease. This group of population are in need of special care and support and also a special protection. I'm very excited to listen from our speaker, audio speaker, Ma'am Rika Desuk. She is here with us to give us to speak with us to speak to us on the topic introduction of palliative care among community healthcare workers. Before I'll hand over the time to Ma'am, I will give an introduction about her. She is a quality nurse in Supercare Hospital, Shillong. She has done her BSc nursing and she has done courses on quality nurse and also course on nursing administration and management. We thank you, ma'am, for taking your valuable time to speak with us to us on this topic, and also we thank you for your being flexible with us to make this webinar happen.
So much. Hello, everyone. Very good afternoon to you all. First thing and foremost, I'm very happy and honored to be a part of the NICE and ISECN platform to share this knowledge about introduction of palliative care for the community care worker. I hope my slide is visible to you all. Is it visible, Miss Ida?
Yeah, ma'am.
The slide is, if you can see the slide.
Not yet, ma'am. We
The
can
slide,
see.
I have already shared the slide.
Yes, your slides are visible. Please go ahead.
Yes, thank you. So first thing and foremost, I want to start with just hold on. I want to start with a quotes or a saying that there are four kinds of people in this world. The one are those who have been caregivers, those who are currently caregivers, and those who will be caregivers, and those who will need caregivers. This has been stated by Rosaline Carter. So we understand that one day, in one point, we will be the caregivers, or we will be needing caregivers. So I want you all to understand what palliative care really is. And I want you to take a very depth knowledge about palliative care, then your perception towards palliative care will be changed. So I hope this session will give you a broad view about it. Before we start off, let's have a scenario. Imagine your neighbor, who is a 50-year-old woman, who is diagnosed with advanced ovarian cancer, has two daughters. One is 24 years old and one is 16 years old. The 24 years old, she is already married. She's with her in-law, and she only have a 16 years old daughter with her. And the doctor said that her disease is not responsive and curative anymore. It's not responding to curative therapy, and likely she is going to die within the next 6 to 9 months. And this patient of ours complained of back pain all over the body, and she looks very apprehensive. So in these conditions, what can you do to help the patient and her family? What are the skills and knowledge or contact you currently have that can help the patient? Or from whom else can you seek further help in this region? Suppose if you are in Meghalaya, from where are you going to seek help and all that? So I want you to really focus on this scenario. And when we talk about palliative, I want you to remember this scenario all along, and you will be able to implement or have a more in-depth knowledge about it. Okay, moving on. I'll leave the scenario to you. You ponder upon it, and we'll move on towards the definition of health by the WHO. WHO says health is a complete well-being of mental, physical, social, and not merely the absence of disease and infirmity. So with the definition of health, let us look to the definition of nursing. Nursing integrates nursing is the integrate of art and science of caring. Just hold on, yes. And then it focuses on the protection, promotion, and optimizing of health and human functioning. It also it deals with prevention of illness and felicitation of health, and also alleviation of suffering and compassionate presence. So you can see that the scope of palliative care do falls in the scope of nursing. So then we understand nursing is not just integrating the arts and science, but it also has a compassionate background towards the patient too. So moving on next, let's see what does the word palliative care means. Palliative care comes from the word pallium, from a Latin word pallium, means cloaked or cover. It means to cover or to cloak the patient from furthermore suffering. So that's where the palliative word comes from. A brief history about palliative care. Palliative care was first originated in 1960 by Dame Cecile Saunders. This lady, Dame Cecile Saunders, she used to work in St. Joseph. So what happened when she worked in St. Joseph, she was working in a hospice care. She then realized that hospice care should be mixed, medical treatment and hospice and palliative care should be mixed together. So she came up with this concept, and she is none other than a nurse, a social worker, a physician, and also a writer. So she then worked into creating the palliative environment, and was then implemented in St. Christopher Hospice in 1967 in London. So some facts about palliative care according to WHO. WHO says that palliative care is a people-centered, and oral immediate release morphine is an essential palliative medicine. And also integrated home care has multiple benefits. So we do really encourage, the WHO also encourage people to the healthcare worker to look into the importance of the home care. And for the fact, children have very less access to palliative care. And these children who have little access of palliative care usually comes, 98% of them comes from the middle and low income countries. And India is one of it. And only about 14% receives palliative care currently. And each year, about 40 million people are needing palliative care, but 78% belongs to the lower and middle income countries. So what is the concept of palliative care as per WHO? Palliative care is an approach that improves the quality of life of the patient and their family. Remember, palliative care does not only focus on the patient, they do focus on the family members too. So it is an approach through which the prevention and relief of suffering is done. And it also works in early detection, in early identification, impeccable assessment, and treatment of pain and other problems like physical, psychosocial, and also spiritual. So what are the myths and facts about palliative care? They often think that palliative care is restricted to only end of life. But no, palliative care is needed from the time of the beginning of the illness and all along the course of the disease. It is not just at the end of it. So the other fact is palliative care is only for cancer patient, but no. Palliative care is not only for cancer patient, but it is for any life-limiting illness, which I will show you in the next slide. You will see what kind of cases involves in it. And palliative care is not the last option. When you have no more hope in treatment, then you turn toward palliative care. That is not palliative care. Palliative care provides a realistic hope of achievable targets, and they restore the dignity of the patient. When you do palliative care, does not mean you are giving up on the patient or you are giving up on the treatment of the patient, but in fact, you are trying to focus on filling life into remaining days and nurturing the relationship. So palliative care is not euthanasia. In fact, people are suffering, a lot of people who suffers from pain end up having the tendency to suicide tendency, or ending up feeling hopeless, powerless, and all that. So palliative care helps to reduce the suffering and thereby reduce the number of people who seek to end their life. So that is the scenario. And the current scenario of palliative care in India, which we all should be aware of, is less than 4% have access to palliative care. We can see turnaround. It's very rare to find palliative care unit in our state, or in our region, or in a country itself. And in 1 in 5 suicide are committed by a patient with advanced or chronic or life-limiting condition. So you can also see that 55 million people every year are pushed below the poverty line by catastrophic health expenditure. The health expenditure are too expensive that they tend to go below the poverty line in trying to seek proper treatment, where we could give palliative treatment for such patients too. And also in India, we have lack of palliative care in our health system, and it affects not just the poor, but it's also affecting the rich. So equally, they are being affected. And millions of bedridden patients, elderly, disabled individuals could not have access healthcare facilities due to the lack of accompaniment or mobility. So that is why home care is very necessary. It's very important. And socially and culturally marginalized group like women, children, LGBTQI, extra, and so on, these groups, marginalized group, are also facing issues to receive palliative care. So I want you to look in this picture, and you will see these are the scope of palliative care. Over the left side, you will see the white area where you see that is the perception of palliative care. You will see there's the one flower, dying flower, and you'll see end of life care. So this is a perception about palliative care. But now I want you to understand this is not palliative care. I want you to see the other picture where there is a plant, where the plants is being watered. The plant is under the sun. It has the bees flying over it. So I want you to understand the actual scenario of scope of palliative care is palliative care works on empathetic communication. You restore the dignity of the patient. You give family and caregiver support. You prepare the patient for the death. I know it sounds very hard for you to understand how are we going to prepare, but eventually when I come to the middle of the topic, you will understand. And also psychosocial, spiritual support, and pain relief, and symptoms management. Pain is something which is unbearable to patient and can make patient goes through a lot of things. So pain relief is very important and vitals in palliative care. And also in palliative care, you need to have an interdisciplinary care and also a community support. So what is the difference between palliative care and conventional approach then? What is the difference between these two? So you have to understand, in palliative care, human dignity is central. But in conventional approach, the disease is central. And in palliative care, your intent is healing. But in conventional, your intent is curing the disease. And the disease in palliative care is you experience to be live, means you experience the patient, the disease, and you live with the disease. But in conventional approach, the disease is the problem you need to solve. And in the goals of palliative care is you ensure life and death with dignity. But in conventional approach, you improve the quality of life. And in palliative care, death is an inevitable reality. Neither you have to hasten it or nor postpone it. But in conventional, death means it is the failure of treatment, which we always want to prevent. The valuable approach for palliative care is for chronic and progressive diseases, whereas the valuable approach for conventional approach is for acute and episodic diseases. So remember, in palliative care, the patient is the sovereign, but in conventional, the physician, the doctor, is the general, is the captain. So just look at these two words. It looks the two sentences. It look the same, but it will give you a very in-depth knowledge about it. In palliative care, don't just do something. You have to be there. But in conventional approach, don't just be there. You have to do something. So I hope this is going to bring you a level up towards the reality of palliative care. So see, there is among palliative, between the old concept and the new concept of the palliative care, you can see over focus towards the old concept of palliative care. You can see that there is active treatment in white color, and then comes the palliative care in the purple color, right? And then comes the death. That is all old perception. We will give active treatment. Active treatment is not working, so we turn toward the palliative care, and then the patient dies. But now, palliative care in the current concept, it starts from the time when the patient is diagnosed with chronic or life-limiting diseases. So in the start of the situation or the diagnosis, you can see that the white color in the new concept, the triangle, the white color is more big than the purple color. So initially, the active treatment is more apprehend or more focused, and the palliative care is doing its initial part. Whereas when the active treatment has reduced, the palliative care will take over it, and then till the palliative care will continue till the time the patient passes away, or till the death. But the new concept does not end there. It also ends in bereavement. Means we have to not only think just for the patient, we have to think about the attendant and the caregivers also. So that is the new concept of palliative care. Who need palliative care? It's not just cancer patient, but patient with severe trauma injury, trauma injury like spinal injury, which the person is going to be paralyzed for the rest of his life, his or her life. They too need palliative care. There will be a burden of giving care to them by the caregivers. So we need to focus on the patient and also to the caregivers. So severe trauma injury also falls in palliative care scope. Old age and other degenerative disorder too. And if you see towards progressive and systematic diseases like COPD, interstitial lung diseases, ILD, heart diseases, progressive neurological disorder like the Parkinson diseases, the Alzheimer diseases, multiple sclerosis, liver and kidney dysfunction, or incurable diseases, SLE and all that, and even HIV, AIDS also. They need palliative care. So who are involved in palliative care team? They are the nurses, the physician, the pharmacist, the physical and occupational therapists, the spiritual and health practitioners, the counselor, the dietitian, the administrative staff, social worker, and even the volunteers. These are the people who will surround the patient and the caregivers as a team of palliative care. So what is the need? What is the need of palliative care in India? Around 2.8 million of new cancer are being diagnosed every year. In India, I'm talking about. And out of which 2/3 are already incurable by the time they reach the hospital. And 70 to 80% of these people, of these patients, have severe pain. That is why we need palliative care. And 80% of the hospitalized HIV/AIDS patients have severe and moderate to, and 40 to 50% of the heart failure have moderate to severe pain, and less than 4% of these patients receive pain relief. So how is palliative different from conventional approach? Palliative care is different because it not only deals with the disease management, it also deals with the symptoms management and psychosocial management. Okay, now we'll move on to the other section. I want you to read this and ponder. The biggest communication problem is we do not listen to understand, we listen to reply. A certain times we had a conversation with our friends or family or patients or anyone. We are just there and we're listening to them, and we just, when they say something, we just want to reply to what they say. But we have to change the concept. We have to understand, not listen to reply, but we have to listen to understand. Then we can improve our communication. So communication skills in palliative care. The definition is communication is a process by which two or more people exchange ideas, facts, feelings in a way they gain a common understanding of the meaning, intent, or use of the message. So why do we communicate? We communicate to deepen our understanding of issues, to convey the information or ideas, to gain acceptance and trust, and also now moving towards the core communication skills in palliative care. Miss Ida, am I going very fast? Is my pace all right?
No, it's okay. It's fine.
Okay, thank you. Remind me if I go too fast. Okay, so the core communication skills in palliative care is you need to be clear and concise. You need to have empathy. Remember, not sympathy, but empathy. And you have to be an active listener. You have to have an open conversation, honest conversation, and then you have to be culturally sensitive in communicating with the patient, and you have to resolve the conflicts. And what if we fail to communicate? If we fail to communicate, it will lead to poor symptom control. If we fail to communicate with the patient is not going to open up with you, and you do not know what the symptoms are. Signs you can see, but symptoms, it comes from them, and you do not know what they're going through. So it will lead to poor symptoms control. And also, if we have poor communication, the patient may not comply with the plan of care because they do not understand, like, what are we trying to do with the patient, or what is our treatment plan. So they will not cooperate with us. And then the poor adjustment to the illness and intervention. If you don't have proper communication, they're not going to accept whatever you're going to intervene. And escalating conflicts. See, when you have poor communication, you cannot capture what the situation or what the error is, and you cannot communicate it to the higher authority. Like, so if you are a nurse, you don't have a proper communication, you don't understand what the patient is trying to do, and you delay the escalating of the symptoms of the patient to the consultants, this will lead more harm to the patient. That is one of the example. And also a lack of effective communication among the team may find an inquiring patient as too demanding. Sometimes we do not have an effective communication among us when we give the handing over about the patient, and then the other person who received the message feels like the patient is too demanding, and they will have a different perception about the patient. So we need to improve our communication. And also medical legal problems stems primarily from poor communication. So the barrier to effective communication, fear of the untaught. Like, the thing is, if we don't have adequate knowledge of it, we fear to say something. So the same thing, the patient does not have an adequate knowledge about the disease, so they fear. So the fear of the untaught is one of the barrier. The fear of being blamed. If the patient talks to you and you're trying to convey the message to the patient, you feel scared that they might blame you for the decisions that they are taking, for the wrong decisions that they are taking. So you fear of being blamed, you fear of upsetting the patient, and you're afraid of saying, I don't know, because you feel like, I'm the healthcare professionals, I'm supposed to be there for them, I'm supposed to know. But if they ask me and if I say I don't know, what a shame. It cannot be like this. So it's all right. Don't be afraid to say I don't know, but do not end only in the term I don't know. You have to say, I don't know, and I'll find out. Please give me time, but I'll get back to you. So you can always break that barrier by doing so. So also unable to manage patient's emotion. Every individual is different, and a patient with certain life-limiting diseases will project a lot of emotion and different emotions. So this patient will have different patients will have different emotions, and if you are unable to manage those emotions, it's going to be a problem. And also unsure about answering difficult questions. So you do not know what to answer. So you're just beating around the bush, and it creates more chaos instead. So the patient also do have a perception about us. Patient's problem in communicating with the healthcare professional is they think that we are too busy. And they also, they think that we are not interested in their physical care. And they think that we do not want to know about their emotional problems, and they are afraid of complaining in case we start thinking that they are too demanding or too complaining. Then we stop treating them. So also they are afraid of getting out of control, or they are terrified of being of having the truth be told. So what is the what is not recommended during clinical communication? Not recommended, okay? Remember, do not at once reply to patient's word. Do not use philosophy or moralize that may hurt patient's feelings. Example, a patient comes and was weeping and was telling you, and out of nowhere you just say, it all happened for a reason. Imagine what will the patient feel? Did I do anything bad that I deserve this? So we have to avoid all these philosophy or moralized situation with the patient, because some philosophy will not be applied to all individuals. So we need to understand what to say. We need to analyze before we say anything to these kind of situations. And we have to avoid false reassurance. Do not pretend to be busy. And also, if you should always explore beyond a physical issue. Don't just look at the signs and symptoms of the patient physically, but you also think about the emotion, think about the spiritual need, think about the social needs too. So do not make assumptions. And also you avoid a superior attitude. And some patients will be having the disease for a longer period of time, and they know the disease better than you, and you feel like, no, I'm the healthcare professional, I should know better than him. So you are trying to show to the patient that I understand, I know what you know, but you are a patient, I know better than you. Like, we should avoid those superior attitude. I'm not saying that we are all like that, or we are like that, but I'm just saying that there are few cases where it can be like that. And do not force your beliefs or conviction on the patient. Example, taking vitals of the patient, or doing an assessment on the patient, and you start convicting them, or do you have pain here? Because you know that if he is having a lung cancer, and then he is going to have difficulty in breathing, and you will say, you're having difficulty in breathing now, it started right like that, no? So you don't put your beliefs or your conviction on the patient. And avoid sympathy. Remember, when you have sympathy to the patient, then you will have attachment to them, then your judgment will be clouded. So it's always to have empathy over sympathy. You wear their shoes, you understand how they are and what they need at the moment, but not sympathizing them. So also you avoid disappearing from stressful situation. You start saying that the patient is crying, so let him cry or let her cry. I'll just go out and maybe I'll come later on, like that. No, don't leave them. You have to be there with them. Remember, you just don't have to do anything. You just have to be there with them also. There are times you need to be like that. And you also avoid both lies and thoughtless and not honesty for the patient. If you look towards the listening wheel, I want you to understand that you can apply this not only in palliative care, but even in your day-to-day life of a healthcare professional. You have to have the clarifying of the if you have any doubt, you have to clarify with the patient. Do you mean you stated this? Do you mean to say in this direction, or do you mean to say it in the other direction? So you need to have a clear, clarified conversation with the patient. You reflect what they say, you repeat what they say. And then after the conversation, you should always summarize the conversation with them. And also open questions. You give them an open question so they can vent out to you. And a short word of encouragement, like saying, yes, I'm listening, yes, go on, so that they'll understand that you are there physically, and you're there with them, and your whole mind and body is there with them, and you're listening for their inquiries, or you're being there for the patient, so as to say, and reacting. You should know how to react to the patient. So the 10 commandments towards effective listening is: number 1, stop talking and start listening. You put the speaker at ease. You show them that you want to listen, and you maintain eye contact. You remove distraction. If you're sitting in a corridor, so many people are working, so you find a little spot where there is a calmness and there's no distraction. You empathize with them. You be patient and tolerate short silence. Don't be in a hurry to finish the conversation. You hold your temper. You don't argue or criticize the patient. You ask questions, and then you stop talking to progress smoothly. And then now you can ask me a question. How come there's 2 points where it's saying stop talking, stop talking? Why? Then it should be only 9 commandments. Why is it 10? Why is it that stop talking is being mentioned twice? Because it's very important to listen. I have a funny quote to show you. See, nature gave us 2 ears and only 1 mouth. That is a gentle hint or a reminder that we should listen more than we speak. So I hope you can apply this in your life too. So, okay, communicating, moving on into the next topic, that is communicating bad news to the patient. Breaking bad news to the patient means delivering information about a serious illness or a poor prognosis or a treatment failure or other negative developments, or that may be difficult to hear or distressing for the patient or the patient's family. That is breaking the bad news. And it is the most challenging aspect of palliative care. So what you need to do is you need to analyze yourself beforehand. Should we tell the diagnosis to the patient or not? If we were diagnosed with the diagnosis that the patient is having, example with cancer, would you want to be told? Or how would you feel if your family hid the news from you? You analyze this. And also, I want you to understand one thing. Why should patient be told about the disease? Is because the patients have the right to know about the disease. And it also allows the patient and the family to plan their life ahead. So it is important to let the patient and the family knows. We will see the 6-step protocol of breaking bad news. Number 1 is the right way of starting. You cannot just come to the patient and say, okay, tell me what happened. No, you have to sit there, be there with the patient, greet them, and you have to introduce yourself. So you need to find the right way of starting the conversation with the patient. Then the patient will have trust on you. And you have to know how much the patient knows about the condition, how much they knows about the diagnosis. And then when you converse with them, you find out how much they want to know, how much they desire to know about their condition. And step 4 is you share information aligned with their knowledge. You should not use so much of medical jargons that they will not understand. So you align the patient's level of knowledge, and you educate them to bring them the right perception. And then you respond to their action. Some will start crying, some will start chasing you out, some will start being blank, some will have panic attacks. So you respond to their action. We thought till that part it's done, but it's not done until and unless we follow the step 6, that is planning and follow up. It is very important for us to recheck the patient, recheck the condition of the patient. That is step 6 is so major. If you accomplish the step 6, it will make your work easy, because the patient then started to trust you and will start venting out a lot of things to you. What is collusion? Collusion is when family members or patients say, please don't tell. This is very common. There are a lot of time where the patient will come, the consultants come, and then told the patient that, see, you've been diagnosed with this, and they will say, no, please don't tell my family members. Or they will tell to the family members will say, please don't tell my patient, don't tell our patient that, she is suffering from cancer, she is suffering from stage 4 cancer, please don't tell her. So these are the collusion, that is the term collusion, and it is a very big or a massive problems for the healthcare workers. They do not know what to do. But let's see, collusion occurs due to what? We need to understand it so that we'll be able to manage it. It occurs because they don't have that trust. There's lack of trust, or they block the grief at a point of time, or maybe they have a depression or suicidal tendency, so they do not want them to know. And then maybe they have unfinished business, so they said, please do not tell, so that they can carry on the unfinished business. Or maybe the person is having chronic anger, which they know, if the person knows, there will be a very big chaos around it. And or maybe the person is having sleep patterns or eating patterns and all that. So you need to understand what caused the collusion, or what is the reason behind them having the collusion. So the steps to manage collusion is, you convey to the relative or to the patient that you are on their side. Do not start to persuade the relative. Why you're not telling? You should tell, you should do this. No, we should let them know that we are on their side. And you acknowledge them that yes, collusion do exist, and we understand. Help us understand why is it so. And you have to explore the family's understanding and insight about the illness and the reasoning about the illness. And then you reassure and explain to them about the disease condition. And then you empathize with the difficult position the family members or the patient are. And then you share information as and when required. Remember, as and when required. And you can start a conversation by saying, it must be challenging for you to maintain the secrecy with the patient, or I think you don't normally keep secrets from your mother or from your father, from the patient. You don't normally keep secrets. I feel this is important. So please think about it. Should you really not tell them, or should you tell them? So please think about it. So you can start off breaking the collusion as such, with such conversation. And anger. Anger is very common in palliative care patients and family. Anger is a response to feeling of helplessness, distress, and fear. It occurs due to loss of control, fear of uncertainty, unresolved issue, pain, and discomfort. So how do you manage anger? You have to be, as a healthcare professional, you have to be very calm, empathetic, and use positive nonverbals. You give time, you give the patient time to express and observe their nonverbal cues, and you acknowledge the reason for their anger, and you arrive at a consensus through participatory decision. You participate in making the decision. You and the patient, along with the family members, you come into one decision, and you summarize the situation, and you assure them that you are going to continue supporting them, and you will follow up, do the follow-up with them after a stipulated time. Means I'll come tomorrow, I'll come day after tomorrow, and make sure you do stick to the promises that you give. So the examples that you can tell them is, example of the words, how you can start a conversation is, I can see that you're very angry. Can we sit down and talk? Tell me what you thought went wrong. How can I help you? Like, start this conversation like this, then maybe it can help you. These are just examples of how you can start a conversation with them. And denial is also very common in palliative, where you see that they refuse to take on board the bad news. So denial can be a problem, because denial can be a problem if the patient do not accept the diagnosis or the prognosis and delay in the treatment. It will delay the treatment. And if the patient is having denial, the patient may minimize the symptoms and implication of the illness. And also, a patient insists of continuing curative treatment, where we know the curative treatment is not going to help them, but still they continue using the curative treatment, which has proven to be ineffective for them. So steps to manage denial. You have to ensure that the denial is not due to the lack of information. If it is due to the lack of information, you should help them understand the misunderstood information that they're getting or the inadequate information. You distinguish between a fact of being denied, example, they refuse the fact that they've been diagnosed with cancer, or the implication of the fact denied, or of example, cancer will not return. So you need to differentiate the stages of denial, and you assess when and how the denial is used, and also you assess the benefits of denial. In certain condition, they refused, they deny the bad news, and it give them a positive outcome instead. So you assess the benefits and risks of the denial. And in some cases where they deny and they end up in doing harm to themselves too, so we need to be very vigilant to it. And if denial is expressed by minimalization of the illness or lack of emotional response, then it is because the patient is being scared. So you have to be there and explain to the patient. You adopt a non-confrontation approach, and also you empathize the patient. So for this, you can start having a conversation with the patient by saying, what do you think about the illness? What are your plans? Do you have any other plans? If there's former plans found to be not working, so you can converse that to the patient. Moving on, I want you to understand to another quote: signs, symptoms, emotion, and physical sensation are the body's method of communication. So now we're going to discuss about few common symptoms in palliative care. I'm trying to pick up only a few symptoms and management also, because palliative care is very vast, but I'm trying to sum it up with the time limit that I'm getting, and I hope I do justice to that. And the symptoms, the general guidelines for managing any symptoms in palliative care is, remember, listen actively, be a good listener. Do not consider the patient's problem as insignificant, and you do not force your opinions or belief upon the patient. You do not ignore the patient's queries, and you do not try to give any false hope, and you ensure confidentiality, and you do not force the patient to talk. So these are the general guidelines which you have to understand and put up in your practice. Let's have a scenario. If you know the answer, you can keep in the chat box. Miss Ida will look into it. So we have a scenario of a 55 years old BD worker. This BD worker patients have high risk for lung cancer, and so this patient of ours, Mr. Sachin, is being diagnosed with advanced stage lung cancer, which has spread locally. He has 3 children. He has very poor chemotherapy tolerance. He had palliative radiotherapy to his chest. He is bedridden, very anxious, and complain of severe breathlessness. So the question is, what must be the likely problems that Mr. Sachin think he would be unable to get out of the bed? And what are the physiological response that would fear to create or would fear that would contribute to his breathlessness? What are the physiological response that contribute to his breathlessness? And how can you help Mr. Sachin? You can write in the chat box what you can help Mr. Sachin with. So as we are seeing Mr. Sachin is having breathlessness, so we'll talk about breathlessness. So what are the useful questions you need to ask when the patient is having breathlessness is, the parameters you want to assess is air hunger, and the questions you can ask the patient is, do you feel like you are not getting enough of air to breathe? And if you want to check the activity level of the patient, you can ask, do you feel breathless when you are at rest? And if the patient it says yes, then the patient is having severe breathlessness. No, even if he was at rest, he's having breathlessness, then that needs to be escalated to the physician. And do you feel breathless when you perform some activity? And if yes, what kind of activities make you breathless? Is it heavy activities or a light activity? Okay. And regarding the position, you can ask them, do you get relief when you assume a particular position? Like if you sleep on the left side, do you the left lateral, do you feel there is relief in in your breathing breathlessness? And if so, you need to make them lie on that position. And also you have to check on the anxiety. Is your breathlessness precipitated by fear or anxiety? Do you feel anxious when you are breathless? You can ask these questions to in correlation for you to investigate about the anxiety for the patient. And also you can ask and see the related situation which is associated symptoms for such breathlessness, for such condition. You can ask if the patient has cough, fever, chest congestion, pain, edema, swelling on the feet, accumulation of phlegm on the throat, rattling, cyanosis, failure, anxiety, or abdominal distension. So you need to know all these questions so that when you escalate it to the physician, you have full history or full, content to converse with your consultants. Okay. So what are the non-pharmacological management? You have to position the patient by making the patient sit upright, and you avoid abdominal or chest compression or restrictive or tight clothes. And you have to open the window. You can keep the electric fan, ceiling fan, handheld fan. Remember, the management that I'm telling you is in a community level. Okay, it's in the community level. And you have to give distraction like relaxation, reading, company, music, TV, or radio. And you also have to conserve the energy of the patient, give them less activity. And you have to control breathing, diaphragmatic breathing. So I hope all of you are aware about diaphragmatic breathing. It is also called as belly breathing. Remember, many of the times we tell the patient do deep breathing, and we can see their chest rising. That is not the diaphragmatic breathing, and it eases them at that particular point of time. But the correct deep breathing exercises where the diaphragm is being pushed down, the abdomen is coming up, so the vacuum in the lungs is bigger and it captured more air. So that is the actual exercise or the correct way of doing deep breathing. So example, you're asking the patient to take a deep breath from their nose. So when you ask them to take a deep breath, their chest is not going to rise. Their abdomen is going to come out. Okay, and you're going to see how, because the diaphragm pushes pushes the organs down, so the stomach come out, and the lungs will have more space to expand. So that is how you teach them how to do diaphragmatic breathing. You can always Google or see from YouTube how to do the belly deep breathing. And moving on, next you have to encourage relaxation of their shoulders and the upper chest muscles. So you can also massage their shoulder, so they will become at ease. And the most important thing you should remember is a person with chest congestions, or they're feeling tightness around their chest, will always say that they have difficulty in breathing. So you need to encourage them to relax. Okay. And deep breathing is very good. It helps even in panic attack also. And then you can give them oral care, and especially if they have persistent mouth breathing. And then if it's not working, then you have to consider for referral. And also another thing is you can wet a towel and you can wipe their face so they feel fresh. So this also help in breathlessness intervention. Moving on to the next investigation, that is pain. Pain is what the person or the people say it hurts. Okay, music. All of you know about it, the visual analog scale, the Von Bunker's faces pain rating scales for pediatric patient, and the other one is visual descriptive pain. So this is very commonly used because you converse with the patient and patient says, yeah, I have slight pain. So you need to understand, okay, slight pain means it can be 1 or 2. And if the patient says, the pain is too extreme, I cannot bear it, it's beyond my tolerance to bear this, means the pain is 10. So this VDS is most commonly used, in fact, but we often ask patient with the numerical rating, pain rating scale. In palliative care, you need to understand pain, the total pain in palliative care means physical, psychological, spiritual, and social pain. It is not just physical pain. It is the 4 parameters that create pain, and that will come towards total pain. So, and we need to focus on all these 4 parameters. Physical pain can cause due to comorbid, or caused by treatment, or caused by cancer. Psychological pain, it can be it is caused due to anxiety, fear of suffering, depression, and past experience of illness. And spiritual can be their anger towards God, loss of faith, finding meaning, and fear of the unknown, and loss of and in social, loss of their job, loss of their social status, and financial concern, worries about the future of their family, and then the dependency. So the PQRST of pain is, these are the questions you can, these are the abbreviation where you can use to approach the patient with pain. You can ask them a question using PQRST. P stands for provoke, or precipitating, or palliating. So the questions you can ask them is, what caused the pain? Then what helped reduce the pain? So you can ask that question so that you will have a depth knowledge about the pain, about their pain. What is the quality of the pain? Is it dull? Is it stabbing pain? You can ask that question so you can understand the quality of pain. And you can also ask them where the pain radiates, where R stands for radiates, where does the pain origin, and then where does it radiates. And S stands for severity. You can use a pain scale and ask them how much would they rate their pain. And you can also ask them regarding the timing of their pain. T stands for time. What time does the pain increase more, during the evening, during the night? Then you will have a concept that, okay, around the evening time we have severe pain, so we will be giving the painkillers around this particular time. So PQRST, I'm pretty sure it will help you even in your clinical experience. Remember to put that into practice, but remember, try to let the patient describe the pain by themselves. Do not tell or do not describe the pain for the patient. You let them describe their own pain. So the pain management is, you assess pain characteristic using PQRST. You assess the expectation of pain. Like if it is injectable, usually it comes down to 15 minutes. And when you're giving oral pain reliefs, it usually goes to 1 hour. So you have to understand what is the expectation of pain relief by the patient and what are you going to give. And then you can tell the patient expected time for your pain relief will be around this time. So you can assess their pain relief expectancy. And also for pain, for patient taking opioids and analgesics, you need to be careful with the side effects, the dependency and tolerance. You massage the painful area as it interrupts pain and transmission. It increases endorphin levels and also it decreases tissue edema. You can use acute pressure as it use the concept of closing the gate. It interrupts the pain transmission. And you can also use cold application. Cold application reduces pain, inflammation, and muscle spasticity. And also you can use hot application where it can reduce pain by improving the blood flow. When there is heat, there is vessel dilation. So there's proper blood flow and there is a relief of pain. You can use TENS. Reduction occurs through a mild electrical current. So as we know that maximum of the patient with palliative care will always have a pain, and the WHO has a pain ladder. So this ladder you see, Okay, so this is in step 1 where the patient is having pain, mild pain, moderate pain. Um, we tend to give them the step 1 treatment, like non-opioid. We are giving them paracetamol or diclofenac or ibuprofen in step 1, and if it does not help, then we increase to step 2 where we give them the weak opioids like codeine, tramadol, and then if still it does not help, then we go towards step 3, which is the higher, stronger opioid like morphine, fentanyl, and buprenorphine. And remember this ladder: if the pain persists or worsens, we climb up the ladder. If the pain reduces, we climb down the ladder. So morphine is here. It's the most common drug that we use. So you need to understand about morphine also. And morphine is a very common drugs which we use in palliative care, and it is often given like 5 mg, 10 mg, and then you should know that the half-life of morphine is 4 hours, so that you can get the gross knowledge of it. That's why the minimum one we give is every 4 hourly. So what are the signs of morphine toxicity is you need to be vigilant that the patient might have myoclonic jerks, over drowsiness, hallucination, or confusion. So one of you please unmute your mic and tell me what antidote can you use for morphine toxicity? Anyone? Are you listening? Hello? Can anyone unmute their mic and tell me the antidote for morphine toxicity? Miss Ida, are you there?
Yes, yes, yeah, I'm there.
Can you unmute one person and tell them to give me the antidote for morphine toxicity? Can anyone?
Naloxone.
Yes, very good. It's naloxone. Very smart. Good. Thank you so much. Yes, it's naloxone. And naloxone, remember, in morphine toxicity, the one thing that we are very scared is respiratory distress for the patient, or suppression for the respiratory suppression for the patient. So naloxone is usually what they used to advise in community area is what they used to do is they mix 0.4 mg of naloxone in 100 ml NS. So they draw every 2 minutes, they administered 0.5 ml of naloxone to the patient. So every 2 minutes they administer the naloxone, and until the patient has gain the respiratory function of respiratory function. And you need to understand that naloxone half-life is 2 minutes, but the half-life of morphine is 4 hours. So you need to monitor the patient for more than 4 hours. Okay, so that is the little hint and knowledge about naloxone. And moving on to the next scenario, we have a 60-year-old man who's diagnosed with a CKD stage 5. He refused dialysis. He has fluid overload, fatigue, anxiety, depression, and then he is also having pain over the back and leg, and he is having nausea and vomiting. So how will you manage symptoms and improve comfort? How will you support the patient's quality of life? How will you address the emotional and spiritual needs of the patient? So you need to have a good knowledge so that you can help him, right? So we will talk about feeling anxiety. He was feeling anxiety, so we'll talk about anxiety. We'll just move on fast because we know, I know a lot of you knows how to manage this. So the management of anxiety is, okay, first, anxiety is a very normal emotion that causes due to increase of alertness, fear, and physical signs. Okay, and the management is lifestyle modification. Acknowledge and validate their concern. You use your presence and touch. Remember, when you touch the patient, you need to assure the patient is all right for you to touch. So touch with permission. Verbalize, demeanor. You accept the patient's defense. You do not dare or argue or debate with the patient. You accept the defense. You communicate with them in a simple language and in a brief statement. You allow the patient to talk. Encourage patient to consider positive talks like, anxiety won't kill me. I can do this one step at a time. So you can use this encouraging self-talk. And also you have to reassure sorry, reassurance is not helping an anxious patient. So you do not reassure them. It's all right. I assure you everything will be all right. No, you do not reassure. You omit that reassurance and you just be there with the patient. So moving on to the last symptoms, that is a caregiver role restraint. We have talked about all these symptoms that the patient have and all that, but there's one major symptoms which we tend to forget. Okay, we tend to forget the role restraint for the caregiver. The caregiver, when they have a palliative patient with them, they do have, anxiety, depression, or anger, or feeling strain. So caregiver role restraint means caregiver feels overwhelmed and cannot perform their role to their best ability. Okay. So the causes, the signs and symptoms will be the caregivers will be forgetful, it become foggy, they don't remember things, they are not interested in things they used to enjoy before, they're feeling hopelessness, they're extremely tired, they're anxious or depressed, they're very quick to anger and easily flustered or frustrated. So these are the symptoms you will be seeing that the caregivers, the long-term caregivers will be facing. So how do you prevent it? So you allow the patient, or you talk to them, or you educate them that they need to find someone to talk to, where you can be one of them that they can talk to. You set realistic goals. Example, they are going to take care of the patient. Let them take care of the patient as much as they can, but you need to tell them that you need to set your goals. If it is beyond your level, you should always learn to say no, or you should always learn to seek help. So you allow them to set the realistic goals. I have example, but I'll just rush. I won't dig deep into it because I know you all are aware about it. And also you have to advise the patient or educate the patient about caregivers about the disease condition. So that they'll understand. Once they understand the disease, the frustration also will reduce. Okay, so you ask them to seek help from their family and friends. You ask them that they are equally important as the patient, so you advise them to attend their needs too, and you have to attend their needs too. Then you have to advise them to eat well, sleep well, which is challenging, but we have to encourage them to do so. And then you have to tell the caregivers that they have to accept the feeling. So moving on to the next, I think this is the last one, I think. Yeah, so evidence-based practices is the foundation of nursing procedure, but experience and intuitions are the guiding lights. So remember, evidence-based is important. It is the foundation for our nursing skills and experience. But a person who's having a lot of experience or exposure to the particular procedures, or they have the intuition about the certain situation, they too should be, they should respect, or they should be alert about the feelings that they have. Okay, so we are going to talk about the management of management and the procedures of a few things which you can find in palliative care. So the scenario is 75 years old woman. She is having diagnosed with advanced lung cancer with respiratory failure. Her life expectancy is 2 to 3 months. She has a tracheostomy tube, and she also requires oxygen therapy and suctioning. And she is a bedridden patient. So what are the primary goals of tracheostomy care for Ms. Johnson? And what are the healthcare team do to balance the need for effective secretion management? And how can you improve the life of Mrs. Jackson? So remember these questions. We will be discussing you'll get the answer in the next few slides. So what is tracheostomy? Tracheostomy is an opening that is made in the trachea to establish and maintain a pattern airway. So you can see the picture over there. And in palliative care patient, we often use the single lumen tracheostomy tube or the double lumen tracheostomy tube, which is a metallic, which is very commonly used for the palliative patient. So how do you clean these two? So the portex, which is the first one, you have to clean this. The first one, the plastic one. So you have to remove the inner tube, and then you have to clean it in the running water. You rinse it with normal saline. you dry it, and then you replace it. And if secretions are there, you soak the inner tube in the normal saline, and then you clean it under the running water. You can cut a piece of suction catheter or brush, then you can clean it. And then you clean the tube with normal saline or soap and gently wash it. And then you tap the tube and then ensure the lumen is clean and there's no water left inside, and then you replace it. But for the metallic one, see, it look more or like the same, but there are a few changes. In the metallic one, after you remove it, you clean it under running water and you soak it in normal saline. Okay, you soak it. The other one, you just rinse it, and in metallic one, you soak it. And if the secretion are present, what do you do is you soak it in the normal saline, you clean it like how you clean the Portex one, and then but what happened in metallic tube is you sterilize it by putting it into the boiling water for 5 minutes. Okay, and then you ensure the lumen is clean, you dry it, make sure there's no water, and then you replace it in. Okay, so a few tips and tricks about suctioning. To do a suctioning for a patient, remember steam inhalation is very important to loosen the secretion. So if you're planning to do secretion, if the patient has a tracheostomy and you know that you will be needing to do suctioning for the patient, you can always adapt the timing, or put the timing for steam inhalation, especially before you do suctioning. It really helps to loosen the secretion. And in times of emergency, yes, you can go ahead with the suctioning first. And you have to prepare the patient or pre-oxygenate the patient when necessary. You limit the suction to 10 seconds or less. And then you block the suction control while inserting the suction catheter tube. And then you unblock the suction catheter control when you are ready to begin the suctioning. So you blocked it, you enter the catheter tube inside, and then when you're ready, you released it, and then you do the suctioning. Okay. When we talk about the steam inhalation, you can also use humidification of air is very important. So what you can do is in the screen and the slide, you can see there's a picture of a humidifier, room humidifier. So this you can buy from Amazon. It costs around 310. This any product, but I'm just showing you this one example. Like, we had one consultant who just gave us an example. Like, do you ever see these Korean movie when the hero or the heroine is sick, by their bedside there's always a steam inhaler, room humidifier, and we started scrolling, and yes, we do really see those. So then we realized the concept of humidification of air is very important. So patient with tracheostomy tube, you can always use these humidifier. If this is not available, it's all right. You can put an electric kettle and you on the electric kettle in the room, let the steam comes in the room where the patient is being kept, and the room will be humidified, and it will be easy for the patient to breathe. At the same time, there will be less thickening of the secretion. And if the patient is having tracheostomy and no oxygen is required at a particular point of time, you can place a wet gauze on tracheostomy to avoid the dryness, and use a humidifier or nebulizer to moisten the air. Moving on towards stoma, ostomy and stoma are used interchangeably. They have different meaning. Stoma means an opening that connects the body cavity to the outside environment. And whereas ostomy means surgery to create an opening. So there are two types of ostomies. One is input ostomies that comes inside, and then the other one is output ostomies, where the input from the patient needs to come out, like waste materials from the human body needs to come out. So that's used for the output ostomies. So input ostomies will be tracheostomy, gastrostomy, jejunostomy, and output ostomies will be ileostomy, colostomy, and urostomy. So this is the example, this is the picture of the colostomy. This is the tracheostomy, this is the jejunostomy stoma. So when patient will have stomas, so you need to know and be aware of few stoma issues. Know that the normal color for stoma is deep pink. And if the patient is having bleeding, you apply pressure for 10 minutes. And then you apply sucralfate powder to control the bleeding. Okay, and if the stoma is dusty in appearance, means it is necrose, you report to the physician as soon as possible. Okay, it needs an immediate intervention. And if the stoma is having edema, usually in the early period, the presence of edema is normal, so no intervention is needed. And if you are aware of one thing, I know you are aware of one thing, that is stoma herniation. So if the patient is having stoma herniation, you ask the patient to lie in supine position. It usually reduces, but in some case the hernia does not reduce, then you should report the situation immediately. Then stoma prolapse occurs because of the weakening of the abdominal wall, like due to the abdominal distension or maybe failure in the surgical intervention and surgical surgery. But you need to have surgical intervention for such case. But before you report it to your consultants, you also need to know that a prolapse of 1.5 centimeters of colostomy outside the skin, of colon outside the skin level, is acceptable. Okay. In case of ileostomy, if the stoma is prolapse of more than 3.5 centimeters, that is acceptable. Okay, but if the prolapse is more than 5 centimeters, then we need to have a surgical intervention and you need to report it. Okay, and then stoma retraction. Bowel movement is not affected, then you don't need to have any intervention. You don't need to do any intervention, but you need to be very, very vigilant and special attention to the skin surrounding also. So colostomy care, surgical diversion of the fecal stream from through the abdominal wall, that's why you need a colostomy. So the types of colostomy pouch you can see is either a 2-piece or a 1-piece colostomy. In the 2-piece, you can see that we have the skin barrier part where you have to paste, and then you put the ostomy bag, which is quite painful for the patient because you need to press it to secure it, no? And then the other part is the 1-piece where there's already an adhesive tape and you just have to apply. And then moving on to the other type, we have a closed ostomy pouch where there's no outlet. It's just a colostomy without a drain. But the other one is we have a drainable ostomy pouch where you can see the drain part. So in palliative care, if the patient is having colostomy, most probably the patient will have the colostomy for a longer period of time. So colostomy irrigation, you need to understand what is colostomy irrigation and how to do the colostomy irrigation, especially when you are in a community area. So colostomy irrigation is a way to regulate bowel movement by emptying the colon at a scheduled time. It involves infusion of water into the colon through the stomach. Okay, who are the candidates for colostomy irrigation? The person with a permanent colostomy, the patient with descending or sigmoid colostomy from the left side, and patient who have achieved adequate healing, stoma maturity, usually 6 to 8 weeks post-op, and patient who are motivated and who are able to perform the procedure. So when do we irrigate it? When do we have to irrigate it? We can irrigate it 1 hour after a meal, or once a day, or once every alternate days, depending on the preference of the patient. It generally takes 6 to 8 weeks for the bowel to, become regulated with irrigation, and also establish a routine and an irrigation at the same time each day. Okay, so what are the equipments you need to do in colostomy irrigation? You need to have a lubricant. You need to have the set of irrigation bag, the tubing, the cone tip. You'll get a ready-made 1 colostomy irrigation kit, and you need to have the clamp, the ostomy belt, and the irrigation sleeves. So what is the procedure? The procedure is after 1 hour after the meal, patient's meal, you can ask them to be in the toilet, in the washroom. In the washroom, or in their own convenient space where they can do the procedure. So what they have to do is they have to lubricate the irrigation cone with the lubricant, and then they have to push the irrigation cone inside the stomach. Okay, not more than 3 centimeters. Okay, they have to push it inside. But before pushing that inside, you need to boil water, 150 ml of water. You boil it and then you let it cool down. and you fill it in the irrigation bag. And the irrigation bag, you have to hang it higher than your head level. Okay, so you have to hang the irrigation bag, and then you put the tube, you pre-fill the tube with that water, and then you clamp it. You put the irrigation sleeves, you secure it with the belt, and the end of it you can put it inside the toilet, okay, and inside the commode, or you can put it in the place where you collect the waste material. Then after that, then when you're ready, you lubricate the irrigation cone. You push it inside, but not more than 3 centimeters. And then you unclamp and allow the fluids to go in. In the first 5 to 10 minutes, the patient, no outcome will come, like no output will come out. Okay, so it's all right. Don't be scared at that particular point of time. Like, and you can advise the patient not to be scared at that time also. Like, you allow the fluid to go in first. So after which, like 10-15 minutes, then you'll start having a secretion. So after all the excretion. So after all the fluids goes in, you clamp, you remove the irrigation cone, and all the waste material will come out. So this is how you do colostomy irrigation. So colostomy skin care, you clean the peri wound with the mild soap and water. You dry it with you dry the skin with soft towels. You use stoma powder or a barrier ring to protect the skin from output. And if the skin erodes, you can use carrier powder. Carrier powder, you can get it from the pharmacy. And you mix this carrier powder with egg white. Sorry, you apply it for 2 to 3 days around the wound, not on the stoma, but around the peri wound, around the wound. Okay. Remember, these are evidence-based practices. Okay, I did not make it. So if this is not available, carrier powder is not available, you can take this zinc oxide paste. You can apply it around the peri wound area. Okay, and remember to always use the right size of bag. And to prevent the malodor, you know, having the colostomy bag, sometimes it has that smell, so you can add charcoal to the colostomy bag. Okay, prevent the malodor. So the diet plan with colostomy, which you as a healthcare professional should be aware. If the patient is having cabbage, garlic, beans, and fried food, it is expected that their stool will cause odor or will have odor. Okay, this food will cause odor. And if the patient is having corn, nuts, cabbage, vegetable peeling, the patient is likely going to have constipation or a hardening of the stool. The stool will be hard. And if the patient is having coffee, fruits, and nuts, and fruit juice and oily food, they will have loose stool. Okay. Mint, coriander, these two will reduce the smell. Moving on to the next procedure, that is nasogastric tube feeding. Remember what is nasogastric tube feeding? You know that it is a plastic tube placed through the nose into the stomach and left in place for providing nutrition and administration of medication or gastric lavage. And articles that you require is dry towel, syringe, glass of water, and glass of liquid food. You know, I'll just move on. So the point that you need to remember in nasogastric tube feeding is you have to check the tube before feeding. You have to aspirate the content. So I hope you all are aware of the GRV. So GRV for the patient, different institute will have different guideline, but this I'm going to see in a community level. So if you're going to feed the patient with 150 ml of liquid diet, so after say after 3 hours or 4 hours, after 4 hours, you need to feed the patient again. After 4 hours, you're planning to feed the patient again. So before you feed, you have to aspirate the content. So if you get a content of more than 100 ml or 100 ml of fluid, you remember, don't throw the fluid, because the patient again will have electrolyte imbalance. So you need to push back the content. And then after you push back the content, you feed only 50 ml, because you could draw 100 ml. So you give only 50 ml and withhold first. Okay, you feed only 50 ml and you withhold. But if you get more than 100, you withhold the feed, and then you check after an hour of feed. If you still get the same, then you better inform your consultant. But if the patient after 1 or 2 hours they accepted the feed, then it's all right. You can go ahead with the next feeding. But always remember to aspirate and check the GRV. And also make the patient sit and use support for prevent aspiration. You hold end of the tube about 12 inches above the patient's head, and then take care not to allow air to enter, and flush the tube at the start and at the end of the feeding. Do not leave the food content on the tube, visible on the tube. And then after every 3 to 4 days, you flush warm saline to prevent coating of the feeding of the tube. And then you make the patient sit 30 to 60 minutes each meal, after each meal. Why do I say after each meal, you have to make the patient sit? It's because they have the patient with the NG tube have the highest risk of aspiration. Usually when we eat, when the foods come to the esophagus, the lower esophageal sphincter opens and allow the food to go in. And after the food goes in, it closes. So it'll prevent aspiration. But now, in NG tube cases, the NG tube is already it's there, and the lower esophageal sphincter cannot close the area, cannot fully close. So there's always high chances that the food content will come out and the patient might get aspiration. So remember, maximum of the NG tube feeding patient die because of aspiration. Okay, so please be very careful with this. Remember, you need to prevent the aspiration as much as you can. And also, you can give small frequent meal, usually 150 ml. And you can also use the bird hammock technique. Over the picture, you can see there are two techniques of how you apply plaster for the NG tube. So in the first picture, you can see the NG tube is touching the tip of the nose, tip of the nose and the bridge of the nose. So if you don't assess this every time, the patient might get pressure injuries, okay, which is medical device pressure injuries. So now the NHS give us an intervention or give us a suggestion, new procedures of how to prevent pressure injuries by using the bird hammock technique, where you take a long cut of the plaster. Then you apply it on the top of on one side of the nose, okay, and then you go from the lower part, you spiral it down, and then in the other end you take it back up and then apply it to the nose. So what happened in this condition is you can see that the tube is not touching the tip of the nose, and this will help the patient from getting pressure injuries, and especially on the fact it prevents the medical device pressure injuries. Okay, so you can Google the technique style, hammock technique style of securing the RELS tube feeding from the NHS. Nasogastric feeding, if you have trouble shooting in it, what you have to do is, if the fluid is not going, check for the placement and for by aspirating the content. And if the tube has slipped out, then you need to put it in, or you need to reinsert again. So check these two things. You aspirate if the content is there or not, and see if it has slipped out or not. And if the tube is in the correct place, you increase the number of flush and clean it with warm saline. Okay. And if the tube has come out and come out completely or has blocked, you can seek advice, or you may be directed to insert the NG tube. And how you have to insert it, you remember the technique of measuring the NG tube. Remember, from the tip of the nose to the pinna to the xiphoid process, and then you insert it, right? So how do you test the placement of the NG tube? Now you can tell me. No, we can use whoosh test. Whoosh test is also proven or shown that it's not really recommended in this scenario or in this current situation. Instead, what we can do is, after we insert, we can aspirate. Okay, aspirate, see what is in, if any gastric content is present or not. And if there is no gastric content, what you can do is, you can take a bowl which has water, which has saline in it, and then you put the tip of the other end of the NG tube, and then you see if there is bubble or not. If there is bubble, it's in the lungs. You pull out the NG tube right away. And if it is not there, then only that time you can use the whoosh test. Now, what is whoosh test? Where you used to keep in 10 cc, 20 cc syringe, you auscultate, the air has to go in and under the pressure that you push through the syringe. So why is that not recommended these days? Is because suppose if you have inserted the you have inserted the NG tube inside the lungs. When you insert it inside the lungs, and then when you do the whoosh test, maybe the patient is feeling very restless and all, but you couldn't. You will be like, wait, it's all right, it's almost done, and you're thinking because the patient's feeling restless because of the procedure. But if the NG tube goes towards the lungs and you push the whoosh test, when you auscultate, you might still hear the sound whoosh. Okay, you might still hear the sound whoosh. But then after some time you start feeding, then you will feed inside the lungs, and the patient will have aspiration and pass away. So that is why the whoosh test is the last resort for you to confirm the placement of the NG tube. And of course, different institute have different policy. You can follow the policy, but I'm just telling in the community-based level. Okay. So malignant wound. What is a malignant wound? It is also called as a fungating wound, where there is both ulcerative and proliferative nature, and these usually develop in the last few months of the patient's life, and they are very distressing for the patient. Okay, this is how it looked like, the fungating wound. Okay, so the management of these common issue is, if the wound is having a bad odor, malodor, or bad smell, then you can clean it with normal saline. You mop the wound gently with gauze. And then another thing, which maybe many of you must have known it, or or you can, maybe it's new learning for you also. You can take metronidazole. You can take metronidazole powder, and you can pound the powder. You make the metronidazole into powder, and then you spread it in the wound, and you spread it around the wound. And other than that, if the patient is having pain while you clean it, and the wound is very dry, so that point of time you can mix the metron powder with the lignocaine. You mix it and you apply it in the wound, so that will help reduce the malodor. Okay, and you change the wound dressing at least twice a day until malodor settles. And the other part is wound discharge. So if the wound is having discharge, then it become wet. So you change the dressing every time it become wet. Okay. And if the wound is having infection, so what you can do is you ask the patient to have a thorough bath before dressing. Then you do the dressing. You clean the wound with normal saline and preferably on the running water, or you flush it with a syringe. And antibiotic may be required. You have to consult the consultants. And regular wound assessment. Remember, all this intervention that I'm giving is in a community level. Okay, it's a community level practices. And then if the patient is having bleeding, always mask the bleeding with a dark clothes, colored clothes. See, if the patient is having, we know that the wound of the patient might bleed, and if she's wearing lighter color, people also can see, she can see. So it disturbs them psychologically too. So that's why we ask them to wear dark color clothes. And if the dressing are not soaked while dressing, the bleeding may occur. So what you have to do is you have to soak it with normal saline first, then you remove it. Okay, you clean the wound by irrigating rather than swabbing. So wound which is very high risk for bleeding, so you use the syringe to flush rather than taking the gauze and swabbing it. Okay, and you use non-adherent dressing. So now in a community level, I'll tell you how to make a non-adherent dressing in the upcoming slides. Okay. So pain management in malignant wound, you can give them a little extra dose of pain medication half an hour before dressing. There will be certain times where you need to do the dressing ASAP, and then again you remember that I have to give painkiller to the patient also. So that does not mean that you'll connect the painkiller at the same time you'll start doing the dressing. You allow the painkiller to work, then you do the dressing. Okay. So at least half an hour before doing the dressing, you give the painkiller. Give time for the medication to work. Okay, you soak previous dressing material and then remove them. Do not open it like that. And then maintain a moist environment for the wound, and irrigate over swabbing for wound dressing, and introduce complementary therapy, music or TV, or communicate with the patient, converse with them, like funny situations they had, or build a rapport with the patient. And if the patient in a community comes to you, or you are going to give a home care for the patient with maggots, what you have to do is you have to apply or flush plain turpentine in the wound with a syringe. So this turpentine oil, you can get it from a carpenter shop, where they used to pour this with the oil to paint. So you can use this turpentine, plain turpentine, and then you have to uh, flush it with a syringe in the wound and wait for 10 minutes. And then you remove the maggots with the help of the forceps. Okay. Repeat the dressing, turpentine dressing, for 2 to 3 days to remove all the maggots. And always keep the wound clean to prevent maggots. But it is sometimes it is unpreventable in certain cases where hygiene is not being maintained. So you need to be very vigilant. Okay, so the tip and tricks for sterilization. Remember, sterilization. How can you sterilize in community level? You do not have a CSSD, so what you can do is you can pile the dressing into a wide mouth, open vessels, and boil it for 20 minutes. You can boil it for 20 minutes. You can use a pressure cooker. You can use an idli vessels. You can sterilize these gauze and cotton in the pressure cooker or idli vessels for 20 minutes. Okay, and then you preserve these. If it's still left, you preserve these, and you repeat every 3 days. Okay, another tip and tricks for preparation of normal saline in a community level is you take 500 ml of water, add 1 tablespoon of salt, and then you boil it for 10 minutes. There you have a normal saline prepared. Okay, and how do you prepare a Vaseline gauze? You cut the gauze in your desirable size. You smear it with the Vaseline. Now you'll say, what Vaseline? We can use this ordinary Vaseline also. Okay, you smeared it in the gauze. You smear the Vaseline in the gauze. You piled it up you put one bowl in a pressure cooker, and then you pile it up. Okay, and then then you pressurize it, not more than 5 minutes. Sorry. Then eventually the Vaseline's 5 to 10 minutes. But be careful, it might burn. So by the time you open it, the Vaseline will melt and has already coated inside the gauze uniformly. So that's how you made a Vaseline gauze in a community level. Okay. And if you are aware of the papaya wound dressing, this papaya, as in the fruit papaya, okay? So you cut the raw papaya, you cut it into thin slice, and you place it directly on the wound before you apply bandaging. If the wound is, if the surface of the wound is even, okay? But if the wound is not even, what you have to do is you scrape and collect the central part of the papaya, you make it into a pulp or a paste, and then you put it on the wound which has uneven surface. Okay, and this has proven to be promoting a lot of wound healing, especially in pressure injury cases. And malador. So if the patient is having malador wound, you can use the Ayurvedic preparation, that is ginger grass. You can keep in 2 to 3 drops of ginger grass oil in ½ liter of water, and you apply it around the wound. Remember, around the wound, okay? Do not apply it on the wound. And then controlling the malador of rectovaginal fistula. Patient sometimes they have secretion and they cannot afford to have a diaper in a community area. I'm talking about, they cannot afford to have a diaper. So what can you do is, sometimes you are using a linen to wrap them around the waist area to collect all the waste material, the urination and the fecal. So what you used to face issues in that situation is you start having that very bad odor, no? So what you can intervene in this part is you can use newspaper. So put several newspaper under the bed sheet below the waist. Okay, below the waist you keep a lot of newspaper. What happened when we keep a newspaper? It's nothing spiritual. I mean, sorry, superstitious belief. Okay, it is just that the carbon that is present in the newspaper is set to absorb the malodor. Okay, the carbon absorb the malodor. Remember, in the colostomy bag also we keep the charcoal, so that's how it works here. Okay. Moving on to the very common symptoms like signs like lymphoedema. That's a accumulation of fluids under the skin, which can be due to obstruction of the obstruction of damage to the lymphatic system. What happened here is we can see the signs and symptoms is usually there is swelling unilateral, and then there is skin changes that will be dry, thickened skin, deep creases, and look like orange skin, and you are unable to pinch. So you remember in lymphedema, remember there will be positive stemmer sign. And what is stemmer sign? Look towards the picture over there where you try to pinch the area, but your index finger and your thumb cannot meet. Okay, so that is stemmer sign. Okay, that is positive stemmer sign. There's also joint stiffness and muscle strain and difficult discomfort and heaviness of and pain. Okay, there are 4 cornerstones of management of lymphoedema in community area. Number 1 is skincare. Skincare, you need to make the skin moist, not dry, but moist. And then you can use coconut oil, and also you can use compression and hoisery or massage or exercise. Okay. So moving towards the compression, you can make them wear the GVT stockings, and you can roll a spiral bandage around the affected limb, and you elevate it, and you can use it for make it for 24 hours. Okay, 24 hours, keep it, but you need to be vigilant for the sinuses of the extremities or the area. And also, if suppose you are going to make the patient exercise, you can also use these compression and then exercise. Okay, so the exercises that you commonly use for lymphoedema, for upper limb, you can ask them to put their hand in front, then you ask them to open and close, open and close. You make them move their wrist forward and back, and then you bend and straighten your elbow, then you roll your shoulder backward direction, and then you have to ask them to lift their hand and then to the ceiling and gently lower it down, and then you have to ask them to raise their hand side by side, up down. Okay, you can use this, you can Google these exercises also, it will be available. And then specific exercise when a patient is mobility is limited, for the patient who's bedridden, you can take their arms and you can bend and straighten them, their hands. You can lift their hands up and then lower it down, and then lift their arms from side to side, up down. And for the leg, you can roll their ankle, and then you can make them sit on the side of the bed, let their leg dangle, and ask them to lift their knee, or you help them lift their knee, and then or you allow them to lift their leg and bend it, lift and bend it. Okay, you can use these exercises. It will help in drainage of the lymphatic system. Okay, the last one is pressure injury. Pressure injury occur as a result. Remember, okay, a lot of us still we are still stuck with the word bed sore, pressure ulcer, but it's not that anymore now. Why is it that it's not anymore? It's because stage 1, there's no there's no sore, skin is intact, it's non-blanchable, so it cannot be pressure ulcer, no, stage 1. So that's why it's converted to the word, the NPIAP has converted it into pressure injury, not pressure ulcer. Okay, and it's not bed sore because sometimes a patient who is chair fast also can get or pressure injury from, not from the bed but from the chair or from the medical devices also. Okay, so remember, it is pressure injury, which I mean the bed sore, which we used to see is pressure injury, and then it is occurred due to a result of tissue being exposed for prolonged pressure, or pressure associated with friction and shear, and other weaker caused by the weaker tissue is caused by the moisture. Okay, So the location for high risk of pressure injury is if a patient is in supine or in a 30 to 40 degree head end, you will always see that the patient will have higher risk with 37.3% around the sacrum and hip region. Okay, and 7% in hip region, 37.3% in sacrum region, and with 29.5% in the heels area. So we need to realize one thing, that pressure injury can occur, and it occur usually in the sacrum, and we need to prevent that. We'll talk about it. Then if the patient is if in prone place in prone area, the facial area is most likely to develop pressure injuries at the highest, and also with 29.4% and 17.9% around the chest area. Okay. So according to NPIAP, any one of you can tell me how many stages of pressure injuries are there previously and now? Anyone? Hello, anyone can tell me the pressure injuries?
Yes, anyone can unmute yourself and answer.
How many stages of pressure injuries are there?
Fourth stage, 5 stages.
Okay, 4, 5, and one more. Can one more guess?
5 stages.
Okay, okay, okay. Now I'll show you. Okay, so this according to IINAP, we have 4 stages, but the other 2 are being added. Okay. Stage 1 is where skin is intact, non-blanchable, erythema, and then stage 2 you will have the partial loss of the dermis, and in the stage 3 you will have full thickness skin loss. You will see the fats, the adipose tissue, and then in stage 4 you will either see the muscle, the bone, the tendons. So now there will be a case where you will see that the wound is there, but there is scar, there is slough, and you do not know what is the bed of the pressure, what is the bed of the wound. Okay, so in that stage, in that condition, that is called unstageable pressure injury. You can only stage, you can only say, or you can only stage the pressure injury after you do the debridement. Okay, so there will be condition where you cannot see the bed of the pressure injury, the wound. So because it's filled with slough and eschar, so that wound will be unstageable pressure injury. After you do the debridement, then only you can come into a conclusion that yes, it is stage 3 or stage 4. Okay, and another one would be suspected deep tissue injury, where you look at the skin. Of course, there's no skin breakage, but it is non-blanchable, but it is purplish in color. Okay, and then you do not understand if it is going to be grade 1, or it's more than grade 1, but how can it be grade 2 or grade 3 also, because there's no skin breakage. So this will fall into suspected deep tissue injury. Okay, and non-blanchable, just as a reminder, we keep on saying non-blanchable, but the meaning of non-blanchable is where you take your finger, you place it on top of the on top of the area where you want to check, and then you release it. And what happened in a normal person, you place it for 3 seconds and you release it, then you can see that blood circulation started coming. But in this stage 1, you will not see the distribution of the blood, the distribution of the blood supply. Okay, so that is with pressure injury. Points to take into consideration is, remember to change the patient's position every 2 to 4 hourly. You avoid elevation of head end of the bed over elevation of the headbed. Usually we say 30 to 40, but what happened is we felt so bad that the patient cannot sit properly, so we elevate the head more than 45 degree, and then they start having pressure around the the body, sacrum area will need to carry the entire weight of the body, and then at that point of time they will develop pressure injuries. They will develop pressure injuries in the sacrum area. Okay, and moving on to the next intervention or the tips, and that is you need to give them extra comfortable devices. like pillows or extra blankets to keep be in between the knees, so that the two body prominent, like the knee, won't be in contact with one another. And then you avoid friction and shear. So, okay, now you can ask me, what is friction? What is shear? See, friction is when there's rubbing. No? This is friction, which the only place where friction is very good is hand hygiene. Friction needs to be very strong. But in pressure injuries, friction is very bad. We don't need friction. We can't afford to have friction in pressure in bedridden patient, because they will develop pressure injuries. And shear is when the patient is, imagine when the patient is you're making the patient lie on the bed, you're elevating the head end, that the area will be pulled, okay, will be pulled, like you can look at my cheeks, and the area will be pulled for longer period of time. There's no straight the anatomy is being disturbed by being dragged or being pulled, no? So that is shear. So there will be inadequate blood circulation during that mechanism, and then the patient will have pressure injuries. Okay, to avoid this, you can always use draw sheet. There are a lot of time where draw sheet is not being utilized. It's just saying that draw sheet is there to prevent the bed from soiling. But no, you can use the draw sheet to lift the patient up, because you need to take care of yourselves so that you can take care of the patient. Lifting a patient with just the patient like that also sometimes is very difficult for you. You'll start having backache, you'll start having muscle tear, or you'll start having muscle spasm here and there. Okay, so what you're going to do is, you're gonna hold, you and your friend are going to hold the draw sheet from the other end, and then you can ask a patient to fold their knees and and push themselves up also, or you can lift the draw sheet. And if you are alone, what you can do is you can go from the head end of the patient. You hold the draw sheet, and if the patient can move, you can tell the patient to fold their knee, and on your count 1, 2, 3, tell the patient to lift themselves up. Okay, so that also you can do. So remember, draw sheet has a vital role, not just to prevent the bed from soiling, but it can help in positioning of the patient also. Okay, and lifting the patient. And also use pH soap and pH soap. Now you're going to tell me pH soap, how pH soap is going to help. I can't understand this. So it's going to be like, I'll frame it in this way. See, the skin has a pH level of 4.5 to 5.7, around those range. So what happens is, we need the soap to be around those areas. The skin needs to be the skin is acidic, okay, because it needs to kill microbes and all that. So what happens is, the soap that is available in the market, sometimes it has good aroma and all that, but it is more alkaline, so it makes the skin dry. Okay, so a patient who is bedridden with the skin is dry, you're using the alkaline soap, so the skin is dry, so it's going to be a lot of challenge for you to prevent the pressure injuries or skin infection. So what you're going to do is, you're going to take the pH soap. Now you're going to tell me which soap has a good pH. Then you can always Google, you can always look from the studies which soap is better. I'm not promoting any brand here, but one of the soap that you can use which has pH level 6, which is more towards, we do not have soap which is exactly at the skin pH, but more towards skin pH is the soap from the company Duff, Fiamma. They're good. They're having the pH 6, 6.7, 6.2, like that. So it comes more towards the acidic, and that's why when you use these product, you tend to see that your skin is very soft. You don't feel dry. That is, and it does not has a lot of foam also. It's because it's trying to balance the pH. Okay, and then you can use coconut oil also to avoid the skin from being dry. And educate the family members how to prevent pressure injuries. The most important thing is, the caregivers should understand what is pressure injuries and how to prevent it and how did it cause. Okay. So the last talk will be on the scopes. Now, many of you might want to pursue a palliative nursing course, and you'll think like, from where should I? Now I'm interested. Okay, now I understand. This is it. Maybe this is my call. I want to be the one giving care to be a caregiver for this patient. So from which course should I looked up to, and also I just kept two sites where you can do offline and online course. So you can always go towards Pallium India, and then from when you Google here, you can get a training over there. You can see the training, and you can get courses like a certified course in pain and palliative medicine or nursing. It is an offline course. You have 6 weeks duration. You have a practical hands-on training in pain and palliative care. Certification will be given. And if you are a BSc and GNM nurse, you can opt for this. You can enroll. And also you can enroll in an online course. So now many of you will think, oh, online course, I can do this so that I'll have a certification. At the same time, I do not have to take leave or do not have to resign from my current workplace, and I can opt for this. So yes, you can. I encourage you, because we really do need a lot of nurses and healthcare professionals to come towards the palliative field. Also, the healthcare system, they really need us to be there for them. And then foundation care and palliative care will be an online course where you can enable nursing professionals to inculcate the principles of palliative care. It will be a 27 hours online session. Certification will be given, and GNM, ANM, BSc nursing can join this course. Okay, and apart from that is you can go to this another online modules where you have 33 modules to cover. You need 120 days, and then you can apply it from the Pallium India. And one more is from the Indian Association of Palliative Care. So what is this founder? The founder, this association, it is the Indian Association of Palliative Care, is a registered public trust society and found in 16 March 1994 in Ahmedabad, and in consultation with the WHO and the Government of India, as a national forum to connect, support, and motivate individuals and institute involved in palliative care. Okay. So the certification course you can get from this association is, if you are a doctor or a nurse, BSc nursing or GNM, you can opt for the course. They used to have around three months. After three months or something like that, you can do the research, and the courses will be charged for 4,000 for the nurses. Okay. And another special thing about these IAPC is, they do have an infographic set in their page. So you can utilize it. You can go to their page, you can open, you can see there will be infographic site. Then you can click there. So in the infographic, what they used to do is they used to teach, they'll give you a small handout or poster about palliative care, or about some procedures, or like a health education type, where you can share in your WhatsApp, you can share it to your friend, where it is very helpful and you can implement it. Like in the month of September, we have the continuation of part 1 of the myth and facts of general myth and facts of palliative care. And even in the month of October, we have the infographic, which continues the myth and facts of part 3 of palliative care. So these, I urge you to look towards these pages and pursue the course, or start reading all these infographic. It will help you. And these are the references that I took. So I hope today's session has helped you, has motivated you, has seen make you see the clearer picture of palliative care, and have the courage to be a caregiver, because the healthcare system do need you. So impart this knowledge, and thank you so much for the platform, and I hope everyone could take away good messages from this session. Over to you, Ms. Ida.
Thank you so much, ma'am. So now we'll have a question answer time. If anyone have any question, you can just put a question in the chat box. Then if anyone has a question, Anyone has anything to ask or clarify?
We have also taken a lot of time. We end on the dot, I guess.
Yes,
So
yes. We thank you so much, ma'am. It's such an informative and interesting session. I personally gained so much knowledge, and also I have and also something to unlearn. Also, it's so beautiful how you explain and how you it is very understandable how you explain the scenarios, and also the correct you explain us how the correct way how to do a deep breathing exercise, a difference between palliative approach and conventional approach, about effective listening, and also about management of various issues related palliative care at a community-based level. I hope this webinar, from what we have learned from speaker today, it and skills and empower us to provide compassionate care and to patients and families facing complex health challenges. So let's work together to ensure that palliative care reaches those who need it most. Thank you so much, ma'am, and thank you. Before I would like to call upon Ma'am Ferisha to please give a thankful speech.
On behalf of my entire Meghalaya team, I would like to take this opportunity to thank all the NICE members for giving us such a wonderful opportunity to conduct this webinar. And first of all, I would like to thank Mr. Shukatali sir, who is our I2nd member, then Mr. Matthew sir, who is our NICE vice chairman, and Mr. Famir sir, who is the NICE general secretary, and Ma'am Denny, who is a national secretary and NICE North Zone head. Thank you so much, ma'am, for guiding us and leading us. And most of all, I would like to thank Ma'am Rika Daisuk Suting. Thank you so much, ma'am, for giving such an informative and giving us your valuable time. Thank you so much. And also a big thank you to our moderator, Ida, and all the participants and technicians. Without all this could not be possible. So finally, I would like to thank all of you present here for making the time to be with us today and helping us to make this successful program. Thank you, one and all.
Thank you so much, Ma'am Ferisha, for the word of thanks. And that's the end for today's webinar. Thank you all. And for the certificate, as usual, you will receive a notification in your dashboard that is in your iSecond account later. Thank you, and thank you. Have a good evening ahead.
thank you so much. Thank you, everyone.
Thank you. You can leave the meeting.